Hello, my name is Amy Downs. I'm Senior Director for Policy and Analysis at the Colorado Health Institute. I've been at CHI for 10 years, and prior to that, I worked at the State Budget Office, where I spent a lot of time thinking about financing of public health insurance programs. And I'm joined by my colleague, Tasia Sinn.
Hi, I'm Tasia Sinn, and I have been at the Colorado Health Institute for almost 6 years. And I normally work on long-term services and supports, but I'm here with Amy today co-presenting about waivers.
So the Affordable Care Act, or the ACA, has been one of the most divisive pieces of legislation passed in a generation. There's a number of reasons for this, but one of the primary reasons is the tension between the role of government and the role of the private sector. To what extent is it the government's responsibility to address social issues? And within the discussion of the role of government, there is a second debate, and that is the tension between the role of the federal and state governments. When should the federal government step in and require states to make reforms, and when should it get out of the way and leave policies to the states? So, how many of you think that the Affordable Care Act is not the perfect piece of legislation and no changes are needed? Now, I can't see all of you, but I'm assuming that many of you think that there's changes that could be made to the Affordable Care Act. And so the big idea of this presentation is that the federal government will be allowing states to waive certain requirements in terms of how the ACA regulates private insurance. And I'm going to be talking to you about some of those opportunities during the first half of the presentation. Now, the federal government is also providing a lot of flexibility in the ways in which states are expanding Medicaid, and flexibility on how they are changing their programs to fit the needs of their population, and in many ways more closely aligning with the values of policymakers in those states. So during the second half of the presentation, Tasia is going to be talking to you about those opportunities and the leniency that the Obama administration is granting states due to some of the political pressures around expanding Medicaid. So if you think back to that tension I showed you between the states and federal government, really what this presentation is about is talking to you about opportunities that can shift some of the power back to states. So we're going to be covering a lot of information in the next 25 minutes, but if there's three things you remember, I hope it's the following. First, states can waive key requirements of the Affordable Care Act. However, they have to meet certain federal standards. Second, states can and are expanding Medicaid in many innovative ways, and they're also changing the way that they're delivering services. And third, the opportunity is now for state innovation. To implement some states are implementing these waivers right now. Others are planning for much more complex waivers to be implemented in the beginning of 2017. So for those of you who are tired of the alphabet soup of healthcare acronyms, we have a new abbreviation for you, and now it's a numerical one. 1332 waivers. Now, this isn't a very creative title, and it simply refers to the section of the Affordable Care Act that authorizes these waivers. Another term you'll often hear is innovation waivers, and that's how we're going to refer to them today, because that's really what they do. They allow states to innovate around the Affordable Care Act. So a good analogy for a 1332 waiver or an innovation waiver is something that it's a waiver that my kids would absolutely love. They want to waive rules around bedtime, around homework, personal hygiene, what they have to eat for dinner. This is their waiver because the door is wide open for states to do almost anything they want to do with the Affordable Care Act. But just like my kids have to get buy-in from me to make rule changes, states have to get buy-in from the state legislature. The ACA requires that a state must have authority under state law to submit an innovation waiver request, and it must also have authority to implement it once it is approved. Now, these waivers, these innovation waivers, cannot be implemented until January of 2017. So basically what I'm going to do is I'm going to walk through 4 different domains where states can waive pieces of the Affordable Care Act. To make this less theoretical within each of these domains, I'm going to give you a few examples of things that states could do. Now keep in mind, These are just examples. I'm just scratching the surface. There's many more policy changes that states could make. So first, with the individual mandate, I think as most of you know, according to the Affordable Care Act, people without coverage are assessed a tax penalty. I'm sure many of you have heard a lot of complaints about this. So what could states do about this? Well, first, states could eliminate the tax penalty altogether. They could change or modify the tax penalty. They could increase it. They could lower it. The ACA also includes exemptions from the individual mandate. For example, people below the tax filing threshold are exempt from the mandate. So states could expand or narrow those exemptions. They could say that more people should be exempt from the individual mandate or fewer people should be exempt from the individual mandate. Once open enrollment only occurs at pre-approved times. It occurs once a year as people try and get health insurance on the state marketplace. States can redefine opportunities for open enrollment and when that should occur. So the next domain I want to talk about falls within the employer mandate. The employer mandate currently includes a penalty for large employers. That is, those employers with 50 or more full-time employees. Full-time is defined as employees that work 30 hours or more a week. And for those employers that fall within this definition who do not provide affordable coverage, if those employees go get coverage through the exchange or the marketplace, those employers will be assessed a penalty. So there's a lot of things states can do around the employer mandate. They could get rid of the employer mandate altogether, or they could modify the amount of the employer penalties. States could exempt certain employers. So I mentioned before that the employer mandate applies to employers with 50 or more full-time employees. They could say that the employer mandate only applies to employers with 200 employees. States could change that very controversial definition of full-time employees. I mentioned that it's currently at 30 hours or more a week. The states could say that the definition of full-time is going to be 35 hours a week or 40 hours a week. They could have an employer mandate that applies to part-time employees. States could allow employers to give their employees a tax-free voucher to go purchase coverage on the exchange as well. The next domain I want to talk about has to do with the benefits and subsidies and tax credits available on the exchange. So the Affordable Care Act mandates that plans sold in the individual and small group markets must include the essential health benefits. So these are different types of services that are required to be provided. So states could modify what is included in the essential health benefits. They could add more services. They could take away services. Currently, as you all probably know, there's different categories of plans available on the exchange or marketplace. Platinum plans are at the very top, that are most expensive plans, but with the highest amount of coverage, followed by gold plans, silver, and finally bronze plans. Some states are talking about adding additional tiers. There could be a copper tier, for example, that has less coverage. Now, you all know that tax credits are available for purchase of coverage on the exchange for people with incomes up to 400% of the federal poverty level. States could lower that threshold, or they could increase that threshold. They could say that subsidies are only available for people up to 300% of the federal poverty level, or they could increase it to 450% of the federal poverty level, for example. If employers offer coverage that is not affordable, states could use tax credits or cost-sharing subsidies to make up the difference. And then the last domain I want to talk about in terms of waivers is within insurance marketplaces themselves and qualified health plan provisions. States can eliminate specific regulations surrounding these areas. So currently, to get subsidized coverage, people have to purchase that coverage off of the state-based marketplace or the federal marketplace, depending on the state that they live in. So states could eliminate the current marketplace structure altogether. They could instead have private exchanges or no exchange. Private exchanges are popping out throughout the country. These are typically a vehicle used by large employers, where a large employer gives employees a certain amount of money to spend and they pick their own plan. So states could allow people to get subsidized coverage through private marketplaces. States could allow people who are eligible for subsidies to purchase their subsidized coverage from any licensed insurer or agent. Currently, they have to go on to the exchange to do that. Now, the Affordable Care Act also includes a small group marketplace where small businesses with up to 100 employees can purchase coverage. It's called the SHOP exchange. States could cap that SHOP exchange for only very small employers, for up to, say, 50 employees, or they could invite large employers to purchase coverage through the SHOP exchange as well. They could get rid of the SHOP exchange altogether. During the ACA debate, there was also a lot of controversy over whether the federal government should create a public option. A public option is really a term used to describe a plan that is sponsored by the government, where the government could act as the insurer, something similar to Medicare. Now, a public option was not ultimately included in the health reform bill, but states would have the option to create their own public option to be sold on the marketplace. So that's just a few examples of some of the things that states can do. There are many, many more. Now, you might be thinking, well, some of these ideas are interesting, but they sound really expensive. How could a state ever even pay for this? And so it's important to note that if the innovation waiver that a state comes up with eliminates things like premium tax credits from the federal government, cost-sharing subsidies, or small business tax credits, state governments can repurpose those funds to fund their innovation plan. That's a really important point, so I want to repeat that. As states put together their innovation waivers, they are entitled to the federal funds that would have otherwise been available to them through the ACA. So this includes federal funds that would have flowed into the states for premium tax credits, subsidies, and business tax credits. It's also important to note that the state can also create innovation waivers that include other federal programs like Medicare or CHIP. They can pool the federal dollars that are coming into the states for their innovation waiver. Now, it's important to note that not everything is on the table. There's some key reforms in the ACA that cannot be waived. I'm going to just address a few of the major ones here, but there are others that are important to look into as states think about innovation waivers. So first is guaranteed issue. Guaranteed issue is a provision in the ACA that says that people are guaranteed to be able to buy health insurance. They can't be rejected based on any of their characteristics, any pre-existing conditions, or past claims experience. Eliminating guaranteed issue is not on the table. All innovation plans must continue to have guaranteed issue. Rating bands are also not on the table to be waived, and that refers to the regulations within the ACA on how plans can be rated or priced. So for example, the ACA doesn't allow insurance plans to charge older folks 10 times more than younger individuals. There's bands around how they can rate that. So that's not on the table. The ACA also eliminated cost sharing for certain preventive services. That cost sharing cannot be added back in. It has to stay, the cost sharing must continue to be eliminated from plans, even within an innovation waiver. Prior to the ACA, plans could alter coverage based on pre-existing conditions. The ACA bans this, and this ban must stay in effect. The ACA also allows young adults to stay on their parents' plans on age 26. That provision is something that is not negotiable. Wondering, what's the catch? What do we have to do? There are some criteria that the federal government will be enforcing with these innovation plans, and they're important to remember because some of them are challenging. First, coverage must be at least as comprehensive as coverage offered through the ACA marketplace. Second, coverage must be at least as affordable as marketplace coverage. Now, for these first two provisions, the federal government has not issued specific guidance on how they would be implemented or measured. So it remains to be seen how much leeway they're going to give the states. Third, the innovation plan must provide coverage to at least as many people as the ACA would have otherwise provided for. And fourth, the innovation plan cannot increase the federal deficit. So states are entitled to those federal dollars that would have otherwise flowed through to them through tax credits and cost sharing subsidies, through small business tax credits, but they are not entitled to more than that. So just talking states that are first out of the gate, we see Hawaii, Vermont, and Arkansas. We don't typically see Vermont and Arkansas on the same slide in health policy discussions, but here they are, both talking seriously about an innovation waiver. Now, in Vermont's case, for years, they've wanted to move towards a single payer system. They saw this innovation process as a way to obtain the federal dollars that would have otherwise come to their state and repurpose that for their single payer system. After costing out their plan, it is currently on hold because there's a big gap between the federal dollars they would receive for an innovation plan and what they think they need to make a single payer system work. Now, Arkansas is on the other side of the spectrum. Arkansas is looking at a possible innovation waiver to introduce not more government, but less government and more market-based reforms within their healthcare system. So they have created a task force to study this issue. Hawaii is looking at an innovation waiver in order to preserve their long-standing employer mandate that they have had in place for a number of years. Now, it's important to remember that there is a potential game changer here, and that is King versus Burwell. This is a case that is being heard by the Supreme Court in March. It is a case that contends that the subsidies provided on the federal exchange are illegal because they are not specifically authorized in the Affordable Care Act. Now, if the court rules in favor of the plaintiffs, this would be a game changer for states using the federal exchange because they won't have access to those subsidies that they would need to fund an innovation waiver. If the plaintiffs prevail, it remains to be seen what the long-term impact would be here in Colorado. Here in the short term, Colorado would not lose its subsidies because Colorado has a state-based exchange. But it's unclear the extent to which there could be ripple effects throughout the country if the plaintiffs prevail. It could potentially destabilize the individual market. It could also require Congress to go in and make some pretty large changes to the Affordable Care Act. So it remains to be seen what the impact would be here in Colorado. So I've spent the last 15 minutes talking to you about how innovation waivers can rewrite the Affordable Care Act. They can be incredibly far-reaching. They can't be implemented until January 1st of 2017. And now I'm going to hand the floor off to my colleague Tasia. She's going to talk about some very specific types of Medicaid waivers that states are implementing now, but these waivers just apply to their Medicaid program.
Thank you, Amy. And so Amy turned it over to me, and like Amy talked about, she was talking about her kids want to waive everything: when they eat, when they go to bed, how much video game time they have, all of that, and those are the innovation waivers. But what I'm going to be talking about, and so just to reiterate what she said, is I'm going to really be narrowing it down to one thing, and that's states' Medicaid programs. So the rest of the presentation will be about Medicaid-only programs, and so we're not waiving other aspects of the Affordable Care Act when I jump into that. So before I jump into talking about those waivers, I want to tell a little story because I think that it really exemplifies the reasons that states innovate through waivers and why we still have waivers today. And so this is a picture of Katie Beckett, and she was born in 1978. And 5 months after she was born, Katie contracted viral encephalitis, and she had to be attached to a ventilator in the hospital, which is where she ended up living for the first 3 years of her life, attached to that ventilator. But by the age of 3, Katie's private insurance, had reached its $1 million cap, and she began to receive Medicaid support for her health care. Doctors eventually determined that Katie could leave the hospital with proper supports at home. However, Medicaid refused to pay for such care, even though it would cost 1/6 as much as hospital care. Under the Medicaid rules at the time, Katie could only receive care in the hospital or in a nursing home setting. An Iowa congressman heard of Katie's situation and realized that it made no sense to keep a child in the hospital who could be at home with her family and cost the Medicaid program less money. So he and her family worked together to convince the Reagan administration that the system should be changed to allow states to provide Medicaid to children receiving care in their homes. And ultimately, President Reagan did take up Katie's cause and intervene so that Katie could receive treatment at home and still be covered under Medicaid. This change in policy became known as the Katie Beckett waivers, and they became available to states in 1982. Colorado was a really early adopter of these waivers, and what we now call them today, we still call them Katie Beckett waivers, but we also call them home and community-based service waivers. And so we adopted our first home and community-based service waiver in 1983. So Katie's story really illustrates why we have a waiver program, and that's to continually deliver Medicaid in more efficient ways as the face of healthcare changes. And waivers really have paved the way for states to test innovations in providing care to Medicaid clients, and it really has changed what the program looks like over the years. So before I jump into some examples of some current Medicaid waivers, I want to give a little context. So Medicaid comes down from the federal government, and they provide rules about how states can provide Medicaid services. But then there are ways to waive some of those rules and really shape what each state's Medicaid program looks like. And so the ways to do that, they can simply waive a current rule, or they can launch a demonstration to test and innovate new ideas, or they can add or expand the program in some way. Now, there are some requirements specifically in the Medicaid program that can be waived, and these are the geographic area, which Medicaid has a statewide requirement, which means that all services must be provided statewide, but states can waive that if a certain area of the states deserves a little more attention. States can also target services for specific populations. So if you think back to Katie Beckett, states can waive certain rules around populations and provide more targeted services. And finally, states can waive the freedom of choice of provider. States can require that their Medicaid clients enroll into a managed care program, which would waive the rule that Medicaid clients have to be able to choose their own provider. So when we think about all these really interesting ways you could combine all of these different options, it's really important to remember that despite having a waiver, states are still responsible for all of the populations that the federal Medicaid rules require, and that the waivers must not cost the federal government any more than it would otherwise without the waiver. So waivers have been around for a long time, and there are three major categories of waivers that fit those requirements I just talked about. The first is the home and community-based service waivers, the Katie Beckett waivers. The second are managed care waivers, and those are where you can require that the Medicaid population go into managed care programs. And the last are the research and demonstration waivers, and this is really where I'm going to focus today. I'm going to probably interchangeably call them 1115 waivers through the rest of the presentation, and each of these numbers on the slide refer to a section of the Social Security Act that can be waived. And so in recent years, states have used these 1115 waivers to really innovate around expanding their Medicaid program to more low-income populations. And so for a little political context, the Obama administration is really invested in states expanding their Medicaid programs to cover more of these low-income people. He's so invested, and his administration is invested, that states are being allowed to test some really new ideas to expand their Medicaid programs really on their own terms through these 1115 waivers. And so we'll talk about a couple of states here later, but they really show the philosophies and the values of the states. They're really demonstrating a sort of new way of moving forward with Medicaid programs. So as of February 2015, currently 29 states, including DC, are implementing the expansion of Medicaid. Nearly all of the states, 24 of them, are implementing the expansion as set forth by the Affordable Care Act, and Colorado is one of those. However, some states are seeking these 1115 waivers to implement the expansion in ways that extend beyond the flexibility provided by the Affordable Care Act. And states are discussing these alternative models through waivers as really politically viable ways to implement this expansion in order to extend coverage and still capture those federal dollars. And again, this really demonstrates the flavor and philosophies and values of these states. So to date, 5 states have received approval for these 1115 waivers to implement the Medicaid expansion, and those are Arkansas, Iowa, Michigan, Indiana, and Pennsylvania. There are 3 other states that have applications into the federal government and are waiting for approval, and those are New Hampshire, Tennessee, and Utah. I'm going to highlight today the 4 states who are approved for their waiver and are moving forward with their programs. So those are Arkansas, Iowa, Michigan, and Indiana. Pennsylvania has elected a new governor who does plan to move forward with expanding Medicaid, but not under the waiver authority that they've been approved for. The last point I want to make here on this slide is that what happens with these waivers over the next couple of years will be really important lessons learned for what happens for how states are planning for those innovation waivers that Amy talked about. And so there'll be some lessons learned about it, some best practices, some really innovative ways to start redesigning how states are providing health care. So before I jump into those 4 states, I just want to pull out a couple of themes from the expansion waivers that have been approved so far. The first is public money for private plans. So this is when you hear about Arkansas's private option. This is where Medicaid clients are able to pick a plan on the private marketplace or on the marketplace, and Medicaid will pick up the premium costs for those plans. The second is monthly contributions and premiums. So this is really cost sharing requirements for Medicaid clients, really having clients put a little money into their Medicaid benefits. But to make sure that they have a choice on those monthly costs, there are also healthy behavior incentives. And so these are, if people meet certain healthy behavior incentives, they're able to reduce or eliminate those cost sharing requirements through the monthly contributions and premiums. And lastly, some of these waivers really have limited benefits that of the Medicaid program that they haven't before. For example, some states are waiving the requirement that Medicaid pay for non-emergent medical transportation. And so it'll be interesting to see the evaluation of all of these different themes that are coming out of these waivers. The final thing that I want to point out here is that all of these themes leverage the private market and rely on personal responsibility for Medicaid clients. First state I want to talk about is Arkansas. And for each state, I'm just going to go through a really high-level overview and talk about what's really unique in each state. And so Arkansas was really the laboratory for the other states because they were the first one to get their waiver approved, and so they've had a lot of attention. And so you may have heard of the private option in Arkansas. And this is where clients are able to pick silver plans on the state exchange, and Medicaid will pay for the premiums for those plans. Beneficiaries aren't required to pay any towards their premiums, but they are required to make, or they do have to make contributions to health savings accounts. The amount of money that they put into their health savings account will depend on their income. And the health savings account, the money that accrues in them, are to be used for the co-payments and co-insurance that they have with their private insurance plans from the marketplace. To Arkansas, people in Iowa will have the choice to enroll into marketplace plans. And for other people in the Medicaid program, they'll be enrolled into the managed care program. And so this, again, depends on your income level, which bucket you fall into. But unlike Arkansas, all of the clients will be responsible for some part of their premiums based on their incomes, but they are able to reduce or eliminate their premium costs by meeting healthy behavior incentives. Michigan is enrolling their newly eligible clients into their Medicaid managed care program. These clients are responsible for paying premiums based on their income, and they're responsible for contributing to a health savings account. But they do also have that healthy behavior incentive to reduce those out-of-pocket costs. we have Indiana, which is the most recent waiver to be approved, and it is the most complex and the most controversial. I'm not going to get into a lot of the details about Indiana, but I'm just going to highlight what's really different. So in Indiana, all the Medicaid clients will be responsible for paying some amount for their premiums. Indiana's waiver is different than the other Medicaid expansion waivers in that it allows the state to lock out Medicaid clients for 6 months who do not pay their premiums on time. And so this is for the higher income brackets. They'll be locked out of their benefits if they're not paying their premiums. Clients are also going to not be enrolled into the Medicaid program until they pay their first premiums. So this is a real departure from the current Medicaid standard, which is clients are enrolled in their benefits upon date of application. And finally, Indiana is also going to provide financial assistance to qualified workers to buy into their employer's health insurance program. So we've been talking about low-income populations, and I want to switch over to talk about long-term services and supports. And the reason I want to talk about this is because it takes up a large portion of the budget. Long-term services and supports are a set of services for people who have functional limitations, and they really range from nursing facility care all the way down to care in someone's home. And so, like I said, they take up a very large portion of the Medicaid. When we look at this slide, and I'm specifically looking at the blue and yellow bars, we see that individuals with disabilities and individuals 65 and older make up just 14% of the Medicaid population, but almost over 50% of the Medicaid costs. And so states are really trying to think about how do we address the specific needs of this population. There's really a lot of money going into serving this population, and so how can we start to think about better ways to serve them? And so this slide shows you a map of states that are participating in a demonstration program to start addressing the needs and costs of people who are both dually eligible for Medicare and Medicaid. So these are people who are low income and have disabilities, and so they are often the most expensive clients for both the Medicare and Medicaid programs. And so there are 12 states who are currently participating in demonstrations to address the needs of this population. And Colorado is one of those states. Colorado is testing care coordination for this population. And so Colorado is trying to increase the amount of coordination that these clients receive in their care, and perhaps be able to reduce some of duplication of benefits or visits to the hospital, and that might accrue in some savings and also provide better care to this population. So we've talked a lot today about a lot of things, and so I just want to come back to the 3 takeaways. And again, the first one is that states can waive key requirements of the Affordable Care Act as long as they meet certain standards. The second is that states can expand and deliver Medicaid in many innovative ways and are doing that today. And last is the opportunity is really now for state innovation. Amy and I would really like to thank you for listening to our presentation today, and we want to encourage you to reach out to us or look at some of the other materials we have on our website. And you can find us on Facebook, Twitter, or you can email us or find us on the web at coloradohealthinstitute.org. Thanks again.